Thank you, ladies and gentlemen. Chairman, first I'd like to thank the organizers, specifically Vipin and Cha, for inviting me and giving me the opportunity to talk. I would also like to thank the previous speakers for setting the stage for this presentation. And then I would also like to sincerely apologize to all of you, because what I'm now going to do is I'm going to disrupt your understanding of our pathophysiological understanding of coronary artery disease, specifically chronic coronary artery disease. So I have no conflicts of interest, except that I believe that knowing facts and mechanism improves patient care. And that's why we have performed reviews of the cardiosurgical literature for the past 10 years, and we have published this with the wording here, cardiac surgery reviewed, and then the year. And if you do this, you recognize certain patterns. And so from that, those patterns, we basically do something, and some of my guys actually have started podcasts. And from those patterns, then, we've witnessed certain things that addressed chronic coronary artery disease. So I said I would like to challenge a paradigm. So what is a paradigm? A paradigm is an overall concept accepted by most people in science because of its effectiveness in explaining a complex process, idea, or set of data. Okay, so what's the revascularization paradigm for stable or chronic coronary artery disease? Well, we all believe, and we've seen this before, and I think that please raise your hands if you don't agree, that revascularization, first of all, which we summarize in PCI and CABG, it treats ischemia symptoms, so it treats angina pectoris. It improves contractile function if it is impaired. It prevents myocardial infarction, and it improves survival. Anybody disagrees? Okay. So what do we do in real life? We have this guideline recommendation table here, and first of all, we look for the type of revascularization, and then we look for coronary artery disease with suitable coronary anatomy. Okay? So we've seen this before. A 3-vessel disease already changed into a 1-vessel disease just because of different interpretations of the type of the disease. But what you need obstructive disease. Okay? So we already select patients that we take for treatment based on certain anatomic features. And that applies to surgery as well as for PCI. Okay, so I thought maybe look at mechanisms and see how coronary artery disease presents and how we can treat it. What are the basic mechanisms? So we have 3 different mechanisms. We have on the left, inducible ischemia, okay? Not ischemia, inducible ischemia. And how do you treat it? There is no, if I have inducible ischemia, I have no ischemia now. I have it if I walk up the stairs. So you need to restore coronary flow capability if needed, but there's no need to change anything right now. There is anything to change right now if I have ongoing ischemia, acute ischemia, and then the mechanism is also known, and we all know how that is called. That's called reperfusion. And then there is something where there is a risk of myocardial infarction and there is no limitation of blood flow at all. And that's the risk of infarction. And the mechanism to treat that is infarct prevention. You take your statins for that. Okay, so with that, if you go further, what happens is your coronary artery disease develops, your blood flows through the vessel, then the plaque is forming. It's coming in a second. And the plaque is forming, and then it causes ischemia at exertion. And if that progresses, at one point in time it occludes, and then you have your myocardial infarction. And then there is another way of doing this. There may be lesions that are not flow relevant, but they may cause things to adhere. And then maybe a little thrombus is forming, and that thrombus takes off, and that occludes things, it embolizes. And it causes another infarction. And that's another mechanism for disease. But the main mechanism for the development of myocardial infarction is this. A non-flow limiting lesion suddenly ruptures, and then a thrombus is forming, and the thrombus formation occludes the vessel, and that is the thing. And if you look on the left side on that graph, you see that the majority, the vast majority of myocardial infarctions are arising from non-significant stenoses. So the flow-relevant stenoses, the severe stenoses, only cause a small fraction of myocardial infarctions. Okay, okay. So what does the evidence show? Let's see. So there's the ischemia trial. The ischemia trial tested whether treating invasively inducible ischemia has an impact on outcome. So the mechanism that you're investigating is restoring coronary flow capability, okay? You know the details of the ischemia trial. What did it show? Well, your inducible ischemia, your angina pectoris that you get from it is less. You have a symptomatic relief. Do you have a difference in mortality? No, none whatsoever. The same outcome as the COURAGE trial before, 15 years before. Same thing, nothing has changed. So ischemia and treating inducible ischemia is a symptomatic relief treatment. You relieve symptoms, but it doesn't seem to have an impact on survival. Okay, so what about chronic ischemia? There's this thing, and then there may be this thing of reperfusion come into play. And which trial assessed that? In order to have chronic ischemia, hibernation, you need to have decreased contractile function. Stitch did that, okay? And Vipin just showed this. Stitch showed a significant survival advantage at 10 years, 18 months longer life if you had CABG over medical therapy. There it is, there is your survival advantage, okay? But here's the treatment, and Vipin also addressed this. On the left side are the patients, the ones he showed, without myocardial viability. And the CABG group still performed better than the medical therapy group. How does that work? So viability testing, ischemia testing doesn't help. It helps in prognosis, in determining prognosis, but it doesn't help in decision making. So if treating inducible ischemia has an impact on survival, another evidence that it doesn't help in deciding how to invasively treat. So, but then of course Revived is able to do this. If the survival advantage that we see in Stitch is due to the fact that there is better flow, more blood flow to the ischemic areas where there is inducible ischemia, then Revived should have shown a difference. But Vipin also addressed this. There's no difference in survival in Revived, not even with heart failure hospitalizations. So reperfusion is out. Chronic ischemia, I'm not sure it really exists. So how do you explain the difference in survival with Stitch? Maybe it's reducing the risk of infarction, but Stitch is not able to answer this because those informations were not gathered in the trial and they didn't follow up specifically on myocardial infarctions. Okay? But there were trials that looked at myocardial infarctions and assessed this, and those were all the trials in comparing CABG and PCI without the evidence of left ventricular dysfunction, the regular comparison, syntax, etc., all these trials. And there's, of course, the Stewart-Head meta-analysis that combined all those trials, and then you had 11,000 patients, half of them PCI, half of them CABG, and there is a 5-year survival advantage for CABG, 2% less death in CABG group after 5 years, right? So there is your survival advantage. And the most important part is this. On the left side here, -10, less infarcts through bypass versus stent. If you subtract the number of myocardial infarctions in the bypass group from the stent group, then you see if a bypass graft, if in the bypass grafting group there was less infarctions, then there was also less death. So better survival associated with less myocardial infarctions. Okay? And this is something that led us to develop the concept of surgical collateralization, where if you place a graft for a significant stenosis, then you also protect against anything else that happens in that vessel at other lesions because you have your surgical collateral. if you treat a flow-limiting lesion with the stent, there's nothing you can do about the infarction that happens at a non-flow limiting lesion. Okay? And since, remember, the majority of myocardial infarctions occur at non-flow limiting lesions, that's why CABG outperforms PCI if the risk of myocardial infarction is high enough. Okay? So, we've done, with Mario Gaudino together, we've done a meta-analysis assessing all trials, randomized, non-randomized, whatever. And we found the usual on the overall at the bottom, CABG outperformed PCI. But if we then separated them into those studies where there was a significant difference in spontaneous myocardial infarction between CABG and PCI, then there was the middle bar, there was a real big difference between CABG and PCI. And if there was no difference in spontaneous myocardial infarction, there was no difference in mortality whatsoever. To the contrary, it moved into the other direction. Okay, so that proved that. So the question then, so the point is that we can make is that if you treat inducible ischemia, you have symptomatic relief. And if you prevent myocardial infarctions, then you improve survival. Okay? But then there are studies that show no difference between PCI and CABG in survival, and how do you explain that? Well, one conclusion is that not all myocardial infarctions are lethal. So this is a noble trial, no difference in mortality, but there's a significant difference in myocardial infarctions. Then there is the patient-level meta-analysis, you know, the big fight about the Excel issue and so on and so forth. So the bottom line, this is the Sabatine meta-analysis, and it showed no difference in mortality, but a significant difference in spontaneous myocardial infarction. Again, CABG outperforms PCI by preventing myocardial infarctions. Syntax, at 10 years, better survival. Why only in the high group, in the high syntax score group? Because I would argue there is the highest risk of myocardial infarction, so the greatest treatment effect with CABG. And you can go on forever, whether it's diabetes, female sex, chronic kidney disease, whether it's heart failure. The sicker the patient, the higher the infarction risk, the greater the CABG effect. Okay, so how do you explain this then? This is a registry analysis for patients with left main disease. And there is medical therapy obviously performing the worst, but PCI is equal to CABG. How can PCI all of a sudden have the same impact on survival than CABG? Well, I would argue because if you die, if the left main occludes and you get a myocardial infarction because left main occlusion, the patient is dead immediately. So there's a great treatment effect if you do something. So the bottom line is, you know, let's go look into the PCI literature a little closer. And there's a meta-analysis from Windecker. And Stefan Windecker, he did this in 2014, 10 years ago. It was a massive network meta-analysis that was very controversial. And that has been, well, anyway. Bottom line is, he didn't only give all-cause mortality risk ratios or rate ratios, whatever he called it. He also gave the same statistical analysis for the risk of myocardial infarction. That's the second red circle. If you correlate those, you already know the image on the left. That's the CABG versus PCI comparison. But look at the image on the right. If you correlate the risk ratios for all-cause mortality from that Windecker analysis, from those trials comparing PCI to medical therapy, to the risk ratio for non-fatal myocardial infarctions, you get a highly significant correlation. So it looks like as if the impact is the same. If there is an impact of PCI on survival, if there may be one, I don't know, then it is probably also through prevention of myocardial infarctions. And now look at the REVIVE trial down here in the spontaneous MI group. You know, there's no difference in overall myocardial infarctions. But if you look on the left side, there's a periprocedural myocardial infarction that is not existent in the conservative group, obviously. But the total number of spontaneous infarctions is larger in the optimal medical therapy group than in the other group. So, you know, there's a balance. So even a stent is able to prevent an infarct, but it has the cost of causing an infarct, and that balances it out. So it's a risk-benefit assessment. So, but it doesn't change the mechanism behind it. Okay, so what about the impact of revascularization on contractile function? This is a retrospective analysis, and they show that there is LV recovery, but only in 60% of patients. This is roughly 500 patients. This is single center, though, not randomized. If you look at the randomized evidence, and Vipin has shown this, no difference whatsoever. So CABG didn't improve contractile function in stitch, and PCI didn't improve contractile function in revived over medical therapy. That's a problem. So if we come back to our revascularization paradigm, you know, we see that there's that revascularization to treat symptoms, yes, we do. Inducible ischemia treatment reduces symptoms, reduces inducible ischemia. But does it improve contractile function? No. Does it prevent myocardial infarction? CABG does. But PCI, maybe. And does it improve survival? CABG, if the risk is high enough. PCI, maybe. So the question is our revascularization paradigm a paradigm that finds overall acceptance? And are you willing, and are you ready and willing to rethink? This is the big question, because what we currently do is not consistent with the data we have. Okay, so here's the solution. Another piece of evidence that supports what I just said. If you look at the coronary CT literature, you find coronary calcium score, and they come up with event rates, and the cardiovascular event rates they find correlate with the degree of coronary disease. They call this plaque burden. It's assessed with a calcium score. The important part is this, at the bottom, whether you have obstructive coronary artery disease or whether you have non-obstructive coronary artery disease doesn't change your event risk. It's the same. So plaque burden causes event risk, not degree of stenosis. Okay? So if you take it then, now I'm summarizing. So you have a vast majority of patients that have non-obstructive coronary artery disease. And then they slowly progress to obstructive coronary artery disease. When they have obstructive coronary artery disease, they get angina. Then they come to the doctor. If that progresses, you get an infarction. But that infarction is only a small fraction of those infarctions that actually occur. And the majority of infarctions come from plaque ruptures from non-obstructive coronary artery disease. And that can only be treated with the collateral properly, at least in the moment. And if you only limit your point to the flow-limiting lesion, you will not be able to address all this. And that's why my argument is, do not revascularize. That term is scientifically inappropriate and not correct. And I say rethink and treat mechanism-based. And with that, I say thank you for your attention.